Andrew is a board-certified internal medicine physician, co-director of the Morris Singer Foundation, and founder and chair of Intend Health Strategies. He is a board member of the Global Health Department at Harvard Medical School and sits on the school's Board of Fellows. And he is a faculty member at Oregon Health and Science University. Sarah brings decades of clinical expertise to her role as Vice President of Partnerships at Intend Health Strategies and has been a dedicated member of the extended team for more than 10 years. Growing up professionally and clinically in the context of relational leadership, Sarah thrives in interprofessional collaborations that support leadership development and health systems innovation, communication, and team-based care delivery. Sarah's work is supported by her experience as a primary care physician at the University of North Carolina at Chapel Hill and as the Assistant Dean for Clinical Education at the UNC School of Medicine, where she was instrumental in building and championing the relational leadership community, RL, at Carolina. Sarah earned degrees in medicine and public health from Emory University before completing her internal medicine residency training at Brigham and Women's Hospital in Boston, It is my honor to introduce you to our next speakers. Please join me in giving a warm welcome to Dr. Andrew Morris Singer and Dr. Sarah Smithson.
Great. Thank you so much, Emily. It's great to be here and part of a wonderful convening. And it's fun to be partnered with Sarah on this. Emily didn't mention this, but Sarah and I actually co-trained together in residency. So it's the band is back together. But yeah, we're really excited to sit with you today, sit amongst people who really understand the value proposition of 5D and all the various things it does as a framework and a tool, share how we've worked with it in the healthcare setting, and then share some of our perspectives on trends taking place in healthcare and how 5D could fit in. So that's the plan. Before I pass the mic to Sarah to introduce herself, I'll share a little bit more. That I'll give you a tiny bit more context on where I'm coming from. So, as Emily said, I'm a former primary care doc. I co-founded the predecessor organization to Intend Health Strategies called Primary Care Progress right after residency. So I've been very involved in healthcare, obviously medical education and academic medicine. The other hat I wear is I'm involved in a number of different foundations. Focused on healthcare, health, medical education, but also political depolarization and bridge building. So I've really gotten to see 5D in the trenches from a bunch of different perspectives. And I have to say, I'm still amazed by how fast it is, the tool 5D, how easy it is to take, how intuitive the findings are, and really enabling different people with vastly different, backgrounds, educations, credentials, et cetera, to communicate clearly, effectively, quickly about it. It's pretty unique. And in healthcare, as Sarah and I are going to talk about, that's very important. And then also, I just love how it connects the three fundamental units in any system. And to me, those are person one, person two, and the work. And my experience with some of these other tools is they don't hit the mark as well as 5D does. So with that, I'd love to pass the mic to Sarah, who is, as Emily said, the Vice President of Partnerships at Intend Health. And Sarah, let's just dive in. I mean, you, like me, you started your career as a full-time primary care doc in the trenches. So tell us how you were first introduced to 5D and what sort of gaps you found it plugging.
Thanks, Andrew. Happy to be with everyone today. And as Andrew mentioned, we trained together in a primary care program at Brigham and Women's Hospital in Boston. And from there, I was really excited to join an innovative care delivery model where I was practicing primary care with an interprofessional team. It was actually a creative development by the president of Blue Cross Blue Shield of North Carolina and the dean at the UNC School of Medicine, creating a primary care clinic that had physicians, physician assistants, pharmacists, dietitians, social workers, and we all work together in a clinical space, which at the time was a very innovative idea. However, we didn't have residents and students. And I really felt like if we were going to be delivering care in an innovative way like this, we needed to have learners in the system. So I was excited in 2014 when I got the opportunity to join the faculty practice at the University of North Carolina, where, of course, I continued doing the clinical care and started focusing on quality improvement. At that time, we were especially focused on becoming more efficient, really standardizing care delivery, similar to what other industries were going through. Maybe we were a little bit behind. I'm thinking about Edie's educated incapacity, but we do have the capacity to learn in healthcare. And so we were really embarking on this quality improvement movement. And of course, I was engaged in medical and resident education. I had a particular passion for interprofessional education and engagement. So the ways that we really fully integrate different team members who have different skill sets and a variety of perspectives fully into a high functioning team, and an emphasis on leadership development. And those interests led me to the opportunity to become Assistant Dean for Clinical Education and Director of Interprofessional Education and Practice in the School of Medicine. So I really felt like things were humming along. I had a real diversity in my career between the clinical practice, quality improvement, medical education, leadership, and it sounds like I had it all, but I started really feeling that tension of wanting to deliver clinical care in a certain way, but feeling the tensions of the external forces, like meeting all of the payer requirements, feeling that vice clamp down on the time that I could spend with patients, and really feeling like internally, we were having less and less time to focus on the relationships with each other, with the different care team members. And so I started leaning more and more into relational leadership to understand how to engage it and leverage it in our workspaces. And so in that context, it was the fall of 2018 when I went out to Portland and was co-training a session in the Relational Leadership Institute at Oregon Health and Science University on teaming, and my co-trainer was delivering the piece on 5D. And I'm a rule follower. So before hopping on the plane to Portland, I did the 5D training, and then I sat in the audience almost as a participant for his delivery about 5D. And I have never had this in a training before. It was like a veil was lifted off of how I was working. So Friday, before I got on that plane, I was working in one way. Saturday did the training, and Monday I showed up in a completely different way with just this new perspective. Whereas before, people who, to be frank, were kind of really getting on my nerves the way they were working, I just was able to completely reframe and see that not only was this not about them as people, it was about their work styles, and I needed what they were contributing in order for us to really create the best outcomes. So luckily, 1 week after that, I had the opportunity to really advocate to bring relational leadership and 5D to UNC. And I do believe that it was the outsized impact that 5D had on my experience that weekend that really motivated me to advocate to bring this type of training to the University of North Carolina. So by the spring of 2019, we had incorporated relational leadership, and we've since trained hundreds of people in both RL, relational leadership, and 5D, and actually thousands more in 5D alone at UNC, which is really amazing. And as much as I loved, the relationships with the patients and being on the cutting edge of care delivery and working with trainees, it just became increasingly clear to me that this work on relationships, Tyler, I loved what you said about changing the world one relationship at a time. We are focused on changing the healthcare world one relationship at a time. And I felt like I could do that more effectively on a national level than only in the clinical space. And so in September of 2022, I joined Intend Health Strategies as the Vice President of Partnerships.
Yeah, Sarah, your story reminds me of my own exposure to 5D. We were launching an innovative new program at our practice, shared medical appointments where groups of patients see the clinician all at the same time. And I was working on a team with a colleague named Linda Joe. And we didn't know it at the time, but we just had totally different energies. I was throwing out ideas of things we could do, how we could approach this new program, and she was just shooting every idea down, just blasting it out of the sky. And I didn't have a language for talking about this. So what did I say? I said to myself, I hate working with Linda Joe, and we're incompatible. And then a colleague said, no, you just have different energies. And I said, what are you talking about? Took 5D, got the results, didn't read it, but my spouse read it and was like, oh my God, this is you. And I said, I'm far too complex for a computer to determine who I am. But sure enough, it nailed it. Anyway, Linda Joe also took the 5D assessment, and it just completely opened up our relationship and really helped us work and talk about process in a new way. Everyone in the practice ended up taking it, and we're off to the races. But it really feels to me, and I know you and I've talked about this, that there's an incredible opportunity in healthcare, really without a robust lift, to improve the way that different people work together during the day, and really change how they feel. And the urgency to do this in healthcare is huge. I mean, the burning platform in healthcare is immense. Sarah, I don't know about you, but I talk to providers almost every day, and I'm not exaggerating when I say that I almost never hear of a provider, a clinician, a doctor, other, talking about doing more clinical medicine, right? Taking on more clinical shifts. It's the opposite. They're backing off, they're disengaging. There's a tremendous amount of demoralization, like we'll talk about. So we got a really urgent problem. And it really feels like 5D and some of the tools that you use in Intend Health are a key part of the solution. So I'm excited to talk more about that. So Sarah, tell folks about how Intend approaches this issue and how 5D fits into the sort of the package, if you will.
Excellent. Happy to. And I'm going to share some slides just to make this a little bit easier to follow. So let me know, are you seeing the slideshow?
Yep, you're good. Full screen.
Great. Thank you, Tyler. Yeah, so I'm also going to lean into what Edie mentioned, which is, present your vision boldly. And at Intend Health Strategies, honestly, our vision is to improve the culture of healthcare and put the people back at the center of the work that we do. And we believe that that happens in part through intentional relationships. And what do I mean by intentional relationships? I don't mean something as simple as grabbing coffee with a colleague or going to a social after work. Those things are great. What they don't address is the complexity of what happens when we bring our human selves into the workspace together. What's happening right now in healthcare is that we see a lot of symptoms, some that you alluded to, Andrew, of isolation, people feeling disengaged. We see people being uncivil to each other in the workspace, these things leading to compromised well-being, and people just flat out feeling unseen, that their values, their perspectives are not only not welcomed, but simply not valued and not being invited to contribute to the work that they do. And these symptoms are manifesting as high turnover, lower productivity, and ultimately avoidable errors. And when errors happen, they harm patients. They also harm the caregivers who are delivering the care and who are unfortunately engaged in those errors. So we have a lot of work to do in the spaces of healthcare. And, I think a lot of our leaders are currently being asked to fix it. You see these huge problems, just fix it. But they're not really given the tools about how to make things better. And I think of that from a primary care doctor perspective, as seeing a patient in clinic, it would be like me seeing their high blood pressure and saying, just fix it. Just will it to get better, even though I know that there are affordable, evidence-based, highly effective strategies that they could employ in order to lower their blood pressure, but I don't offer them any of those. I just say, you know what, just will it down. And that is what we are asking some of our leaders to do when we say, these are big problems, just make them better. This is actually the space where intent health strategies thrives and where we see Simpli5 and 5D as a key element, a foundational and essential element to improving the culture of healthcare. So with our expertise in clinical care delivery and leadership development at Intent Health, we really zoom out and say, okay, what is the underlying cause of these problems? And one is simply the complexity of the work. So we know that there are so many moving parts in healthcare and so many different team members who come into a shared workspace to do the work together. And this work is high stress, it's high stakes. We're talking about people's physical, emotional, psychological well-being that's on the line. And there are fewer and fewer people to do this high stakes, high stress, very complex. Did I mention it's constantly evolving? We're saying, do it more efficiently, be more fair about it, make sure that you're spending less money. That is just a massive amount of complexity that makes this workspace really complicated. Then there are the aspects of knowing others' work. Because this work is so complex, we often get stuck in our silos, understanding, say, what I do as a physician, or a nurse understanding what they do as a nurse, or a front desk administrator, what that person does. It's rare that we actually understand the degrees of the work that other people are doing and the way our work directly influences another person's ability to get their work done. I mentioned the fact that many people operating in this high stress, very complex space with fewer people who don't know each other's work, they simply don't feel valued. They don't feel that their perspectives are sought out. If they are sought out, their feedback is not fully incorporated. They don't see themselves in the work that is happening. And as you might imagine, when these three previous factors come into a common space together, there's exceptional potential for tension and conflict. And few people really feel well equipped to manage that tension and conflict in the moment. You might imagine that we see 5D and the power of 5D as essential in this work that happens, along with some of the other aspects of our work at Intent Health.
Yeah, it's so interesting, Sarah. This knowing others' work bucket is so important. Obviously, there's the what of the work, but also the how and the why, and that's really where 5D, I think, just nails it. But I remember early on in a training we were doing, a physician and a medical assistant who worked very closely, and we gave them this exercise of really understanding what does the physician do behind the closed door. With the electronic medical record, with the patient, what is the medical assistant doing when the physician's not in the room, prepping for that? And the two of them, they had no idea what the other person was doing. They had no idea of the specific steps, and they had no idea the things they were doing that created obstacles for the next person. And it so much had to do with the electronic medical record. And I just remember these aha moments for them. And then you add in this layer of the sort of how and the why they go about the work in that way. And, the physician maybe who's more of the examine person, and they're asking questions and, pointing out where there are flaws in someone's plan. And maybe the medical assistant is more execute. And all of a sudden they realize that the other person is not trying to be annoying to them. It's how they operate. So those epiphanies are so important. Because when you think about what happens when we don't have a language for that in healthcare, people don't just collide. but the personalization of these moments and really taking it personally when maybe the physician who's got high exam and is poking holes in my idea or pointing out the flaws, I take that personally. But then you take the stakes of healthcare and just pour jet fuel on that reaction. So people are tense, people are angry, people are feeling hurt. And then 5D just becomes this, this solve. Sorry, I just came up with that. That probably is not the best frame, but you know what I'm saying. This therapy for that. So it's really great. So Sarah, what is the solution when you are coming into a clinic to work with an intact care team, when you're working with hospital leaders? How do you get them to take the relational medicine pill, if you will? How do you sugarcoat it?
Yeah. Well, I think, Andrew, you raise a really important point, which is that, we're asking people in these environments to do so much with such a degree of stress. And, no matter how much reframing we try to do in that space, it is a relative space of scarcity, that whatever intervention we attempt, it has to be straightforward, simple, easy to implement. And so our model overall is one where we take a simple framework. You mentioned leaders and executives. Yes, we hope that these simple models speak to them. We hope these simple models speak to anyone working in a healthcare space, regardless of their years of experience, the degrees hanging on their walls, their level of training. We really want these things to be simple to understand. Then we move that framework into a really practical tool. So for instance, one of the strategies we start with is narrative leadership or storytelling. We use a really simple framework. We give a simple tool, this practice of storytelling, for them to put into practice. And in our trainings, we say, this isn't just a module you're going to flip through on the computer. This is something we're going to engage in and be really experiential. And so we have folks practice these skills in real time. You alluded, Andrew, to the folks that we're working with, and it makes me think again to educated incapacity, right? That Edie mentioned. Many people think, I don't need to understand how to be relational. These are soft skills. I know how to be a nice person. That's all I need. And so we usually do experience a bit of skepticism. And so people are really surprised when not only do these skills work when they engage with them, but they have a really positive experience with using them. And they're able to take the simple framework, practical tool, positive experience, and put it into repetition in real life, which leads them to build relational muscle memory. So they take it and they're adaptable. You can see how 5D fits this model to a T, right? Simple framework, really applicable. Take it into different settings with you. It works. It feels good. Boom, you want to use it over and over. And that's the same framework that we use with different skills, inviting stories from others, creating cultures of feedback, managing conflict. And we found it to be particularly effective.
Yeah, and this notion too of making it simple, making it so people can really just get an experience of it. Positive for them, positive with others, and start developing that relational muscle memory. That's so important. Here's the other thing. Healthcare is an industry that is very focused on fixing problems, its own problems, and moving us forward into the future. So as we all know, or you might not be aware, conversations about diversity, equity, and inclusion are very important. This is work that really needs to be approached thoughtfully with care. And what I like about 5D2 in healthcare is it enables us to talk about difference and add to this, difference conversation in a way that might be more approachable for some folks. Obviously, it's fun and funny. One of the things I always love is, you can always hear laughter coming out of a room where people are talking about 5D. And I think that's really important because some conversations around conflict management these days and difference can be tense. Sarah, I'd love us to shift to talking a little bit about the future. Obviously, not everyone on this call is in healthcare. And obviously we don't see everything in healthcare, but we've got some unique vantage points. So we're going to share a few perspectives, trends that we see in healthcare right now, and ways that we think 5D might be applicable. And we're just going to bucket into the three major constituencies: the learners, who are current medical students, nursing students, medical residents, et cetera; the practitioners, people in the trenches right now and increasingly leaving; and then the patients, families and communities. So Sarah, you've been in the thick of medical education since your residency graduation. What are you seeing, and how does 5D plug in? I feel like Tom Ashbrook here.
Andrew, this is a question near and dear to my heart, with an emphasis on the learners, who are the future of any work that we're doing in healthcare. And, there's just been such an explosion of medical knowledge that we know we can no longer teach students, medical students, nursing students, physical therapy students, the facts alone and expect them to be successful. We need to teach them how to work effectively in teams, how to learn from each other, how to continue learning in the context of clinical complexity. I think diabetes is a great example. When you and I were training, we had two primary types of diabetes and a handful of medications. Now there's just been an explosion of technology with pumps and monitors, and there are many more forms of diabetes recognized, so many medications. It's hard to keep up. And so understanding how to effectively work with each other, learn from each other in our clinical settings is exceptionally important. And so for our students to be a catalyst for this kind of engagement it's actually a great opportunity. And at UNC, this most recent class of new medical students, in their orientation, there are about 200 incoming students. They all learned 5D. Dozens of the faculty who will be teaching them also learned 5D. The plan is that they will incorporate 5D into their curriculum, into their changing small groups over time, so that each time their small groups transition, they can look at their spider graphs, engage with their 5D energies. And in 18 months, these learners are going to be in the clinical setting where we know we're actually having an exodus of practitioners. These students in particular can be a substantial catalyst for culture change in that setting, bringing with them an understanding of 5D that then we hope they will apply and teach other colleagues in the clinical spaces. So really exciting time in medical education. How about the practitioners?
Well, it's funny you asked that, Sarah. To be totally serious, the practitioner perspective is dark. I mean, this is really a dark time for healthcare practitioners right now, and I'm not going to sugarcoat it. I mean, we've got major levels of burnout, major levels of demoralization, people leaving or retiring early, or indicating that they're planning on leaving in a relatively short period of time. And those who are staying, the reports that we have are people are less engaged. They're less engaged in volunteering for different committees, teaching, innovation, et cetera. So this is something we're going to have to contend with. And there's a negative synergy here. More people leave, more of the work that's complex is on the shoulders of a smaller group of people, which makes it more overwhelming. No one wants to be the last person on the boat, if you will. So look, that's something that we're going to have to contend with. But obviously, we're hopeful. Simultaneously, as Sarah said, we have fewer people, but the expectations are higher. You're not just delivering clinical care these days, but you're innovating. You're expected to innovate. You're expected to measure, make it safer, make it more equitable, more standardized, more efficient. So that's an important trend, and showcasing how 5D can be an important piece of planning that work, but also retroactively looking at work that's been done that didn't achieve our goals and why 5D is an important lens. AI incorporation into healthcare and medicine is obviously going to be very important. Everyone's talking about it right now. It is happening. And I think the general thought is that 50% of AI in medicine will be amazing. It's going to make things exponentially better. At the same time, the other 50% of what's happening with AI, it's very concerning, and potentially could be catastrophically destructive. And we have to be very careful with it. The problem is no one knows which 50% is which. And I hope I'm not talking too glibly about this, but that just seems like where we all are. And then obviously longstanding issues of inclusion, diversity, belonging, respect, etc. There's a much greater focus on that. 5D has an important role to play there. And then finally, interprofessional work. That is increasing. The reliance on other members of the care team, community health workers, patients and their families, reassigning roles and responsibilities, and a sense of loss that is inevitably associated with that for some professionals. That's also a piece of the puzzle here. And you can immediately see the implications of 5D here. And Sarah, why don't you take us to patients?
Yeah, I think, patients, if we think about this in two different settings, I'll speak to the inpatient setting, and then you can take us home with the outpatient setting. I think you mentioned the expansion of the care team. Increasingly patients and their family members are being incorporated as members of the care team. And we can imagine how understanding how patients and family members engage with information and work through what's happening to them in the context of an understanding of how other members of the care team are doing the same could really be an important way for patients to be more fully incorporated into the work that's happening. Even things like occasional labeling that may happen from a care team, speaking about, oh, that patient or their family, they're difficult, or they're really disengaged, could be just a misunderstanding about how they're processing information, or they're leaning into their examine energy by asking a lot of questions. You mentioned this earlier. Having a language with which to discuss these differences could really bring the care team and the patients closer together.
Yeah, and in the outpatient setting, just trends around expectations. Your average patient and their family has just, as they should, they just have much higher expectations of the care they're going to receive, the way they're going to be communicated with, the speed of responsiveness. It's just much higher. And they're voting with their feet. I mean, they're increasingly able to get their care through telemedicine and online. Target and other big box stores are offering some of these services. So healthcare's, that increasing fragmentation, it just means that there's more competition in those entities that are really serving patients where they are, giving them additional tools that are going to help them in healthcare, but in other aspects of their lives are just going to fare better. Another trend that's going on in healthcare is just monitoring apps. Your average patient increasingly knows what their heart rate is, knows what their blood pressure is, knows how they slept last night. They're tracking it all, and they're sharing that information with the clinical team. And sometimes it's helpful, sometimes it's not. But that's another thing that just is a fact. So we've said a lot, and we want to definitely save some time for questions and comments. So Karen and Simpli5 team will rely on you.
Yeah. Thank you both so much. I was very excited to hear your talk today, and I think the work that you are doing is outstanding and so impactful for all of us, even if we don't work in healthcare, because I think that each of us are a patient at some point in time. I do have some great questions. I actually want to start it off. So just really quickly, I found myself at age 30 as a cancer patient with a cancer diagnosis in a very scary situation. And it's why I mentioned this is very near and dear to my heart. I was met with a care team in this room, and all of the information was being thrown at me. And, it's very scary in that situation. But unfortunately, I had a nurse who was supposed to be my main point of contact step into the room and say to me, do not reach out to me between these hours or these days. You only contact me if you need this. And I am a high excite, and that only added to the anxiety. So thankfully, my oncologist who came in is also very high excite himself, and really took the time to kind of explain everything to you. And it really is so important. And it's so important, for them to even be able to have those conversations with patients and really kind of speak their energetic language, as we say, to have that knowledge themselves. So I love what you are doing and kind of bringing awareness around that. And with that, I kind of want to lead into our first question. So it says, I love what Five Dynamics has done and what you have done for learners and practitioners, but what is it going to take the next step and bring patients into this equation? So historically, the price has been prohibitive, but we now have a lighter version at a very affordable price point. Imagine how patient outcomes could go up based on speaking their language and giving them what they need every step of the way. So how do you all see that changing?
Yeah, yeah. Andrew, do you want to take it, or you want me to?
Why don't you go first, and I'll see how you respond, and then I'll add.
Yeah, now I'm biased because I absolutely think that the perspectives of every member of the care team are essential. It's like looking at a piece of art from different perspectives and experiences and talking about the vase and the faces, right? What do we see when we look at something? How could we move forward and get a complete picture without incorporating the patient perspective and patient voice, and understanding how they're thinking and processing and what they need? I was getting goosebumps when you were telling your story. Like, that just feels essential to me. And, Andrew spoke to this a little bit, but I think investing even a small amount of money in that space of more fully incorporating the patient's voice and creating a more cohesive team together, that is walking the walk of living your institutional values if you really claim that people and patient care is your top priority. I've heard the quote that your budget is your social contract. Where you spend your money as an organization speaks to what you value. And so to me, this is directly aligned with a people first organization.
Yeah, and I would just add that I think there are going to be some early adopters here, systems that experiment with this and pilot it and showcase through actual outcomes and surveys that patients really like it, and the care teams also really benefit from having that additional information. So I'm really looking forward to seeing that, and I think the price point is such that this is totally doable for these systems.
Great, thank you. Next question. I've got a few questions here, so I'm going to try to get through them. It says, I would love to see your successful application of the 5D approach throughout the healthcare space improvement process. Could you please share your personal insights and tips on how others can integrate 5D into their regular practices for enhancing their own professional spaces?
So I would just say that number one, giving people the opportunity to learn about their own strengths and what they bring to the table in an interdependent care, interdependent team setting is just really important and valuable. Because I think a lot of people on teams walk around, like, especially, like, for instance, high examine folks, they walk around feeling like they're getting negative signals from colleagues a lot. So to see something objectively that really showcased the value and the strength, I think, is very important. And to help other colleagues understand the why, these wired tendencies that are really not going anywhere. I think that's really important. So just giving a common language, giving some positive experiences, it goes a long way, I think, to building goodwill and understanding. And then, as it relates to the work, I'm just finding that using 5D framework to plan work proactively, thinking about the different dynamics, thinking about teams, especially sort of ad hoc teams that come together on certain stuff, or looking at work retroactively. Hey, here's what we had hoped to accomplish. Here's what ended up happening. But let's think about this, in the context of 5D. Were we too heavy on certain energies, or did we spend too much time in certain dynamics and skip over other dynamics? I just find that can really help people work more effectively together and develop insights.
Absolutely. Thank you. So our next question is for Sarah. We heard from Dr. Lynn Fiskus from UNC at last year's summit, and she shared some phenomenal data with us around increased physician engagement, increased patient satisfaction, and increased healthcare outcomes. But what I'm curious about is, what resistance did you meet at UNC when you tried to roll out this program, and how did you manage that resistance?
Oh, great question. And yes, shout out to Lynn, who does exceptional work. I think UNC is a huge system, and as you might expect, incorporating one more thing, one more aspect that, requires teaching and a team ultimately to deliver. People will feel like, I don't have time for this. I think the beauty of it is when you engage with 5D, you work more efficiently. You don't have to go back and redo the work over again because it failed the first time, because you get it right. And so I think it's really been about having people do it. When we deliver a Relational Leadership Institute, I think probably the call we get the most for people wanting to spread content to their work areas is for 5D, because they see that, they experience that positive feeling, they take it, they want to apply it, they want to have the shared language. And so it's really been about finding the influencers, not the social media influencers, but the people in the workspaces who may or may not be formal leaders. Sometimes they are, sometimes they're not. Who are the people who really influence the culture of a space, getting them to try 5D and have their light bulbs go off or their veils lifted, and they then want to take it back to their spaces because the efficiency is that much greater for them, and they can really see the power of it to be successful in their units.
Oh, that's great. We hear that so often from our customers. It's always that moment of, I get it, and I can't wait to share this with everybody else. So it's nice to hear that goes throughout. And I just want to be respectful of time. I know we're coming up here, so we've got time for one last question. So our question is, at the heart of healthcare are people who need treatment, the patients, and people who want to help them, the providers. So how did it get to be this way with so much pressure from the top and so much burnout and a lack of people being at the center of care? How much of this is influenced by insurance and the constraints that come with it?
Yeah, I mean, this is the $1 million question, literally. I think it's the $1 trillion question now. But with I think a lot of things in life, it's complex and it's a multiplex, a multitude of forces. It definitely feels to us that the corporate takeover in many ways of some of these institutions has played an important role. Consolidation, standardization, the drives for efficiency, the electronic medical record that has clearly created some benefit, but it simultaneously created a lot of issues. And in your average encounter right now, it takes up a tremendous amount of the attention of the average practitioner, who really has to feed this document. And that takes them away from focusing on the patient right in front of them, focusing on the relationship. Increasingly, we have things we have to do in order to be reimbursed by Medicare, Medicaid, private insurers. And frequently those things are not on the patient's agenda, and they're not on our agenda, but we have to get to them. So, a lot of providers these days feel that they're increasingly practicing in a manner inconsistent with their values and why they went into healthcare. It's one of the things people say that are pulling them out. At the same time, I'm incredibly hopeful, because the next generation of folks coming to medical school, nursing school, social work school, et cetera, These people are really committed to patients and community health. They're really committed to improving the systems. They're really committed to leveraging technology in a smart way, because obviously technology is going to help us, but we have to be smart about it. So I'm very hopeful, but it's going to be rocky before it gets better.
Well, thank you so much both for your time. This is so fascinating, and I want to be respectful of that. But thank you so much for sharing today and for joining us and all of your information. I'm so sorry for the questions that we did not get to.